All right, let's get right into it. We're about to explore one of the most intense dramas in all of medicine, a story that plays out entirely inside our heads. It's all about a fixed space, rising pressure, and a brain that is literally and desperately running out of room. This is a story of a squeezed brain.
And really, this is the central question we're tackling. See, unlike pretty much any other organ, your brain lives inside this rigid, unforgiving box of bone. There's no stretch, no give. So when things start to go wrong, when something starts to swell or bleed, what happens? What has to give?
To really get a grip on this crisis, you have to start with the fundamental law of the land, neurosurgically speaking. It's called the Monroe-Kelly doctrine, and honestly, it sets the rules for everything that's about to go wrong. Okay, think about it like this. The skull is a sealed container. It's totally rigid. And inside, you've got just three things: brain tissue, blood, and this fluid called cerebrospinal fluid, or CSF. The key takeaway here is that the total volume of those three things cannot change. It's a zero-sum game. So if a tumor starts growing or there's some swelling, something else has to get squeezed out to make room. There is literally no empty space to spare. So when everything's normal and healthy, the pressure inside this box, we call it the intracranial pressure, or ICP, it's pretty low. It just kind of hovers around 10 millimeters of mercury. This is our baseline, our physiological happy place. But as you're about to see, this number can change, and it can change frighteningly fast. So what happens when a new player enters the game? A bleed from a car accident, a rapidly growing tumor. Something new starts taking up space. That delicate pressure balance gets thrown into absolute chaos. And the body, well, it has to respond. So who are the usual suspects here? The main troublemakers. Well, it usually boils down to one of three things. First, something new is physically taking up space, what we call a space-occupying lesion, like a tumor or a bleed. Second, you could have widespread brain swelling, which is called cerebral edema. Or third, there could be a plumbing problem with the CSF, a condition called hydrocephalus. Every single one of these is trying to add volume to a box that simply cannot expand. Now, the body is pretty clever, at least at first. It tries to compensate. Its fastest trick is to just push some of that CSF out of the skull and down into the spinal canal. Kind of like pushing water out of a full glass. It can also try to squeeze a little extra blood out of the veins. But here's the catch. These are just short-term fixes. The body is just buying time, and that clock is ticking down fast.
And this is where things get really, really dangerous. Because as that pressure inside the skull rises, it gets harder and harder for fresh blood to get into the brain. The brain tissue starts to sense it's suffocating, a state we call ischemia. So it does what seems logical. It screams for more blood. It does this by dilating its arteries to open the floodgates. But here's the tragic irony. All that extra blood flowing in increases the total volume inside the skull even more, which jacks up the pressure, which makes the ischemia even worse. It's a deadly, vicious feedback loop.
So as the body's defenses start to fail, the patient starts showing the signs. You'll see a headache that just keeps getting worse, often in the morning. They might start vomiting, sometimes projectile, with no warning. If you were to look in the back of their eyes with an ophthalmoscope, you might see papilledema, that's a swelling of the optic nerve. And they'll start to get drowsy, their thinking slows down. These are the first crucial clues that the pressure is winning. Now, if that pressure just keeps climbing, the body sends out one final, desperate SOS. And this isn't some subtle clue. This is a flashing red light with sirens blaring. It's called Cushing's triad, and it's a terrifying sign that the brainstem itself, the most primitive and vital part of the brain, is being crushed. This triad has three parts. First, you get hypertension. The body skyrockets the blood pressure in a last-ditch brute force effort to shove blood past the compression and into the brain. Second, you get bradycardia, which is a slow heart rate. This is actually a reflex response to that crazy high blood pressure. And third, you see irregular respirations as the breathing control centers in the brainstem start to sputter and fail. I really need you to remember this. Cushing's triad is not an early warning sign. It is a late and deeply ominous sign that the brain is on the absolute verge of herniating. The crisis isn't coming anymore. The crisis is here. So when all compensation has failed and the pressure is just overwhelming, the brain tissue itself has nowhere left to go. It gets physically pushed or squeezed out of its normal compartment and into a space where it does not belong. This is herniation, and we're going to walk through 4 deadly types, each one a neurological catastrophe.
Okay, first up, and the most common type, is called subfalcial herniation. This is what happens when pressure on one side of the brain gets so high that it starts to shove brain tissue sideways, forcing it under a tough dividing membrane.
So specifically, a part of the brain called the cingulate gyrus gets shoved underneath that midline divider called the falx cerebri. Now, the real danger here isn't just the squishing, it's that this herniation can kink and compress branches of the anterior cerebral artery, or ACA, which cuts off blood supply to some really important areas. And you can see how that artery compression leads directly to the clinical signs. The ACA supplies the part of the brain that controls leg movement, so you get leg weakness. It also feeds parts of the frontal lobe that handle motivation and personality, so patients can become really apathetic, sometimes progressing to a state of akinetic mutism, where they're awake, but they just don't move or speak. All right, next up is the classic transtentorial, or uncle herniation. This is the one that is drilled into every medical student, and for good reason. You have to be able to recognize this one, and fast. What's happening here is that the innermost part of the temporal lobe, a little hook of tissue called the uncus, gets pushed down over the edge of another tough membrane called the tentorium. And as it goes over the edge, it crushes three incredibly vital structures: cranial nerve 3, which controls your pupil, the midbrain, which houses our consciousness center, and the posterior cerebral artery. And this is just a beautiful and terrifying example of how anatomy predicts the symptoms. When you squeeze cranial nerve 3, the pupil on that same side becomes fixed and fully dilated. This is the classic blown pupil. When you compress the consciousness center, the ARS, the patient goes into a coma. And when you put pressure on the midbrain, you get a very specific and awful type of abnormal posturing called decerebrate posturing.
And this is a really important distinction. Abnormal posturing tells you a story about where the injury is. In decorticate posturing, the arms are flexed inward, like they're being pulled to the core of the body. This suggests the damage is higher up, above the midbrain. But in decerebrate posturing, everything is extended outward. This points to a much more severe injury at or below the midbrain, exactly what we see in an uncle herniation.
Our third syndrome is central herniation. So unlike the sideways push we just saw with the other two, this one is a dangerous straight-down displacement of the entire brainstem. You can think of this as a top-down failure of the brainstem. It starts with drowsiness as the upper parts get compressed, and it relentlessly progresses to coma. You'll typically see small but still reactive pupils, that classic up and down Cheyne-Stokes breathing pattern, and the development of that decorticate to the core posturing we just talked about. And finally, we arrive at the most rapidly fatal herniation of them all, tonsillar herniation. Let me be clear, this isn't a warning sign. This is the absolute, catastrophic end stage of unchecked intracranial pressure. It's often the point of no return. In this disaster, the lowest part of the cerebellum, called the cerebellar tonsils, are literally forced down through the opening at the very base of the skull, the foramen magnum. And what sits right there, waiting to be crushed? The medulla. This is the part of the brainstem that controls your breathing and your blood pressure. This herniation directly crushes your body's life support system.
The clinical signs are as catastrophic and immediate as you'd imagine. A sudden, complete stop in breathing, a rapid, total collapse of blood pressure, and then death. There is almost no time to act once this process begins. It is devastatingly final.
So, faced with this impending disaster, how do we possibly fight back? Well, this is one of the truest emergencies in all of medicine, and it is an absolute desperate race against time. Every strategy is aimed at one thing: reversing that deadly pressure buildup. First and foremost, you have to treat the cause, stop the bleeding, get the tumor out. Medically, we can use powerful diuretics like mannitol to literally pull water out of the swollen brain tissue. In the ICU, we might briefly hyperventilate the patient to constrict blood vessels and buy some precious time. And if all else fails, a surgeon can perform a decompressive craniotomy. They actually remove a piece of the skull to give the brain the one thing it needs most: room to swell. So we've traveled all the way from a simple rule of physics inside the skull to its most catastrophic consequences. We've seen the early warnings, the late-stage alarms, and the final deadly pathways. So now, putting yourself in the shoes of a clinician, knowing the clues and knowing the terrifying speed of each, which one of these herniation syndromes would you be most afraid to miss?